Welcome, everyone. This is a re-recorded program from the International Conference on Patient Advocacy that took place in April 22. Today, we're going to hear from Rebecca Abraham, who is going to speak on the cannabis elephant in the room, who's using and why. Rebecca Abrams is an RN, BSN, and the president and founder of Acute on Chronic. Acute on Chronic was the first cannabis nurse clinic in the Midwest. Rebecca has trained and worked at some of the best academic centers in the country and is board certified cannabis nurse through the American Association of Cannabis Nurses. Rebecca is currently attending North Illinois University and enrolled in the Doctoral Nursing program. Rebecca was awarded a continuing education scholarship from the National Nurses United to Rutgers University Women's Global Health Leadership Certificate Program. In 2015, she was awarded the Illinois Nurse Association's 40 Under 40 Leaders in Nursing Award and was a scholarship winner in the 2012 Nurses in Washington Lobbyist Internship. Rebecca remains an active member of the American Nurses Cannabis Association, National Nurses United, Patient Advocacy Alliance, and the Sigma Tau National Honor Society. She has testified and lobbied for healthcare, patient safety, nursing, and cannabis policies on the municipal, state, and federal levels. She's currently a national speaker in healthcare and cannabis community. She also proudly educates physicians, nurses, and the cannabis industry on cannabis science, safety, patient therapeutic uses, and the growing of cannabis nursing. I'm proud to turn this over to Rebecca for her presentation.
Okay, so hi everyone, I'm Rebecca Abraham. So yes, this is all I do. Former ICU nurse of 13, 14 years. And I noticed there was a really big gap in care. Doctors weren't talking about this, nurses weren't talking about it, patients needed information. They were going to the cannabis industry and they didn't have the information either. These two sides do not talk. So I left critical care nursing. I also used to do case management. And this is all I do. And then my doctorate, I am getting a doctorate in nursing, a dual nurse practitioner to doctorate. And my nursing doctorate project is actually going to be on bridging the gap in cannabis care and making it accessible, and what happens when we give patients cannabis early in the care course versus later, and how well do they do. So there are lots of types of cannabis. This is just a few. So back before 30 years ago, there were really you only took cannabis in one way. You smoked it, you ate it. Globally, there's actually been a lot of different ways to consume cannabis. In today's market, this is just a handful. So this is a balm. These are gummies. Gummies have become very popular. This is a vape. This is an oil. And I have some examples of oils here. They also come in tablet form. This is something called a wax. This is chocolate. So, and then traditional flower. So as you can see, a lot of different ways you can consume cannabis. So the history of cannabis is something I go over briefly because it is such a stigmatized substance and should not be so. So I oftentimes go over the history of cannabis just to have everybody have a better understanding of how we got here and where we came from and how do we get back to that. So medicinal use of cannabis begins actually about well over 3,000 years ago. 2500 BC China is the earliest known date. It ended up in a Chinese text about medicine around this date being used for several things like pain, relaxation. We see uses of cannabis throughout Asia, Africa, Northern Africa, the Middle East. And then we see it move over to Europe, after the Roman Empire. We see in the medieval period it is used. Even in the more modern period, at the beginning of medicine, cannabis was one of the most frequently used substances in the late 1800s and 1900s, all the way up to 1937. What happens in 1937? So that is the year where cannabis became prohibited. Why did it become prohibited? There's no scientific reason why it was prohibited. In fact, there wasn't even a safety reason. A lot of people assume something happened like the opioid crisis. Not at all. What actually happened is where capitalism meets racism, right? So we have Andrew Mellon, who is the, I believe, Secretary of the Treasury. He owns a very large stake in the chemical company DuPont. And then we have William Randolph Hearst. You may know him from being a huge newspaper operator, but he also owned a lot of paper products. He sold paper. He owned the paper he printed on and he sold it. Hemp, ever since the days of American colonialization, hemp was actually a major export for the United States, next to tobacco and cotton. It was actually the most second used. The founding fathers had hemp farms. Thomas Jefferson smoked hemp for his headaches, George Washington too. So way, way back, hemp is a very prominent product. So why do these two men all of a sudden target hemp? Well, they lose money to it. So they were thinking, what on earth can we do? They hire Andrew Mellon's nephew-in-law, Dr. Anslinger. Now, if you've seen the movie about Billie Holiday that was out a couple years ago and won an Oscar, this is the same man that went after Billie Holiday, and they found something convenient to do. They were going to take a slang term they made up. So we have capitalism, racism, then sexism, and they started saying that women were using this substance called marijuana. Remember, not a real term, and it was making them be promiscuous. And the jazz musicians were starting a social movement like Billie Holiday, and that this has to be stopped. You see films like Reefer Madness. That's where this period comes from. The AMA did not know at the time that marijuana that Congress was talking about, and Andrew Mellon and the new formed narcotics department, and cannabis were literally the same substance. 2 days during congressional hearing, during those last 2 days, two physicians from the American Medical Association come to Congress and say, please do not ban this substance. This is what works well for our patients. It's one of the main medicines we use. We are just discovering new scientific discovery. We can do a lot of research here. Do not ban this. Congress says, no, we won't. They put it under a Stamp Act. The tax on the stamp was never made. And then it becomes prohibited. There's about every decade a government report, which is in the Library of Congress. You could pull it up if you like. Every 10 years, the federal government has a scientific study where they show, should cannabis still be a Schedule 1 regulated substance? And the answer is always no. There is no potential for harm or abuse, and there is great therapeutic benefit because we actually have some FDA approved products that are made out of cannabis. So that is the history. And so I just like giving that as a baseline for this is why we need to push back against stigma. It was made up by people trying to do bad things and make more money. So like I said, cannabis is a safe substance to use overall. There has actually been billions of dollars of research poured into finding what's dangerous about cannabis. And that's actually where we find a lot of the medicinal benefits. They can't find it. There's really no other substance where we pour that much money into finding the wrongs of something. Only about 1% goes to therapeutic benefit. And it's very safe. So safer than a lot of pharmaceuticals and even over-the-counter substances like Tylenol or even ibuprofen. When you side to side, which I'm going to do, compare side effects of cannabis and these even over-the-counter pain relievers, cannabis still has a better safety profile. Another thing that's really great, there is no lethal dose of cannabis. You can go to a dispensary, you could eat the whole thing. You will not die. Now, there's also never been in the history of cannabis, a death reported related to marijuana, or I'm sorry, cannabis. We don't call it marijuana anymore because it's an old racist term, but no deaths related to cannabis. The government does still call it marijuana, which is why I slip up, something we need to aggressively change. But no related deaths unless somebody does something truly foolish, like drive and crash their car. Very different, but that can also happen on a multitude of other things. So we have 20,000 plus growing global studies. Every month it adds. The United States does studies on the system, oftentimes preclinical studies that the cannabis works on, but globally we do have a lot more research. And then pharmaceutical companies are trying to synthesize it. So we get a little bit of information from that. But overall, plant-based cannabis versus the synthetic, plant-based is always better. I'll explain why. So that's where we have in cannabis, we can oftentimes work backwards because we know it has this robust safety profile. So here's Billie Holiday and Dr. Anslinger. They battled it out. He tortured this poor woman her entire life. So how does cannabis work? I talked about these laboratory studies on the system cannabis works on. Cannabis works on the endocannabinoid system. If you haven't heard of the system, that's okay. Most people haven't. It is embedded in our central nervous system, and it does talk to every single organ system that we have. What does the endocannabinoid do? What we know so far is it likes to maintain homeostasis in our body. So, what's that? The cell signaling. So, it does talk to most of our cells to make them do the function that they are meant to do in a very um, static way. So it always wants to rebalance us, balance, balance, balance. And what does the system touch? Temperature, blood sugar levels, pH balance, water, minerals, metabolic waste. We actually do make our own internal cannabis, hooray. Some examples of that are things called anandamide and 2AG. And when we do things like eat, have sex, run, have pain, do pleasurable things, do unpleasurable things, we do actually see in studies these anandamide levels change. An example is there was a sexual health study done in 2017 where after a sexual encounter you see a drop in anandamide. That means you're using that up. So the theory is that why does cannabis help with so many things is because it works on this system and it likes to rebalance. So if you have a decrease in anandamide 2AG, in theory, the plant-based cannabis can help us. So, how is there no lethal dose? The endocannabinoid system is robust and everywhere except our brain stem. So it does not stop respiratory, it does not stop respirations, and it does not stop our hearts. So there's no risk of death like there is to opioids. And then the two main receptors of the system, there's a couple, CB1 and CB2. These are abundant throughout our body. And they react different ways to cannabis, but all in a very positive way that helps the plant-based cannabis as well as our own internal cannabinoids work. The cellular function, I won't get too into the weeds on this, no pun intended, but the endocannabinoid system is pretty complicated, but all of it works in a very unique way. Even on the neurotransmitter level, the messaging is sent backwards. It sometimes does multiple things. There's just so much, it's very unique. So when a patient says, why would I try cannabis when nothing else in medicine has worked? I always encourage them to give it a chance why it is safe and because the system is so unique that we truly haven't tried this modality. So we do see oftentimes relief in things that have not been treated well with traditional medicine, and cannabis comes in really great. Qualifying diagnoses for a medical cannabis card vary from state to state. There's about 36 states with legal medical cannabis, 37 if you include Washington, D.C., and well over 10 with recreational cannabis. So multitude of symptoms and disease processes that can get you a medical cannabis card depending on your state. Where I could speak from the Midwest, California, New York are some of our markets. And so, in that chronic pain, migraines, post traumatic stress syndrome, seizure disorders, fibromyalgia, traumatic brain injury, irritable bowel syndrome, um, inflammatory bowel disease, your Crohn's disease, your ulcerative colitis, any type of cancer, anorexia, any kind of wasting syndrome, EDS, I never say this right, Ehlers-Danlos syndrome, glaucoma, hepatitis C. So this list is not even complete, but no, it varies states to state. And there are more states trying to legalize recreational as well as medicinal cannabis. So I talked about how the endocannabinoid system does talk to every single system in our body. This is a little bit of a complicated picture, but I like the mapping of it, so I often share it. So how does cannabis work? I mentioned it can work in a multitude of ways. And here's just a really easy drawing of the several pathways it works on. So for things like dementia, anxiety, agitation, your cannabis is working on this, the HPA, that is the hypothalamus pituitary adrenal axis. What does that system do? It controls our fight or flight, our sympathetic response, decreases stress, helps with our circadian rhythm. We see cannabis helping control cortisol levels, decrease insulin resistance. So, a lot of really important hormones and neurotransmitters move through the system, and cannabis can often help regulate that. That's why we see people with decreased stress as well as decreased anxiety, and we see a little bit more regulation with sleep. That's why you hear people say, cannabis gives me energy, cannabis gives me sleep. It's because of the circadian rhythm. How does it help for pain? Two different pathways. Cannabis can oftentimes change the visceral sensation of pain and also alter the pain messaging. So that is one way. It works a lot on TRPV1 receptors. If you really want to get into the mechanism of action, those are a set of neurotransmitters that do a pretty important job. On the other end, we have seen really potent anti-inflammatory effects, very similar to your ibuprofens, your Motrins, your naproxens, but without the side effects. So works on that same inflammatory pathway, which is COX-1, COX-2, but we actually see a similar result without the side effects. So that's another way that cannabis works and can be really beneficial for patients. And then bowel motility, as well as regulating bowel diseases and disorders. There is a relationship between gut brain health. About 20 years ago, that was kind of people in medicine rolled eyes at that. Turns out the gut brain connection is true. So we quite yet don't know the modality of this. I actually have a note from another lecture I just gave regarding this. Um, but we do see, some cannabinoids have antibacterial properties. We want good gut health. So there's a there that we don't quite understand, but also this could help with constipation and diarrhea as well. Um, you hear me say the word cannabis. What is cannabis? Is cannabis the same as marijuana? Is cannabis the same as CBC? So, cannabis is the overarching grouping of all of this. So, cannabis and marijuana are one of the same. Remember, the term, it was just plucked out of nowhere. What falls under cannabis? Underneath cannabis is CBD. So, same, it's just under the umbrella. THC, THCA, and what these are is very specific therapeutic molecules that exist within the cannabis plant. What kind of plant you have depends on what profile of these exist, plus something called terpenes. I'll get to terpenes, I think, in a second. So terpenes are the essential oil of cannabis. There is something called hemp, which is high in CBD, low in THC, and then there's what is referred to high THC cannabis, formerly known as your marijuana. But no, there's 162 of these compounds. We can extract them individually, and they have therapeutic response, but oftentimes they work better together. The combination we pick is based on the studies we have and what we know these things to do. So if you are a person with, or you have a patient with something like really severe rheumatoid arthritis, a really good combination for them is probably something like a THC, a CBDA, and a CBG. When we do our work, I'll get more into the weeds about that. We actually do a robust assessment, drug interaction check. We look at meds, we look at the whole person, what they've tried before, how they metabolize. It's a whole process of how we nail down particularly which cannabinoid we use and how much of it. So I'll talk more about kind of the main cannabinoids we start seeing and using. So CBD, most people have heard about by now. It's gotten a lot of press. People say it helps with pain, sleep, anxiety, seizure disorders in children we've seen. So what's awesome about CBD, it is not altering. There are little to no side effects, no withdrawal symptoms, and it can control a variety of symptoms from pain, stress, anti-seizure control, so many things. CBD, we see it do, which is really neat. It also helps people tolerate THC. So oftentimes THC is something that stimulates appetite, makes people sleep, and the CBD component oftentimes helps us tolerate that. THC is another one everybody's heard of. This is what gets you high. This is what brings the euphoria. This is what gives cannabis kind of the stigma and the bad rap. So this is the only mind-altering psychoactive substance that exists within cannabis. It is great for acute pain and acute symptoms. It really is great for nausea, appetite control, and sleep. And euphoria is often a side effect, but we tell people, embrace this. It's not bad to have euphoria. it was made to be a bad thing, but it's a quite pleasant side effect, and it does not it's not associated, this euphoria, with increased use disorder, with addiction. It's just present, particularly if you have a chronically ill patient, somebody who's an older adult, somebody who has depression, anxiety related to their disease process. That euphoria can really be a great tool and a side effect to use. I often encourage people to do pleasant things when they're using THC, of course, in the safety of their home or someplace that they're going to be for a while. Painting, art, music, watching movies, taking a walk through nature, those kind of things can be really satisfying. I've seen people, their first time having euphoria. I have a couple of older adult patients where their kids have given them cannabis and they wanted me to sit there to see how it went. And the mood change on some of folks it's really awesome to see. And they're laughing with their grandkids and they're like, I've never seen grandma like this. So don't run from the euphoria. And then CBG, this is the newest cannabinoid, behaves like CBD, but potentially better, not mind altering. Oftentimes we see less side effects and a little bit of a better effect, actually. It's a little more difficult to find. We have a little less research, but the patient data is growing quite fast. We're seeing really good results. Again, places I see fantastic results, decreased in dementia and delirium, even in facilities. For the facilities that have let us do our work, we're seeing really good results, decreased daytime sleepiness, increased nighttime sleeping, and then less episodes of anxiety and agitation. The other thing it's great for is any kind of neurological process, neurological pain, inflammatory pain, and appetite boosting. So be on the lookout for this. This is probably going to be the new CBD soon. So I talked about terpenes. That also affects what type of plant we're using. You may have heard the word strain. Terpenes are the essential oils that exist in plant life. So they exist in cannabis too, and they do have therapeutic properties. A little less robustly researched, again. But the studies we have on terpenes all look very positive, and there are anti-inflammatory effects and anti-anxiety effects of many of these things. So why do we use so many cannabis products together? Why terpenes? Why CBD plus THC? Why am I talking about three compounds? We suspect that cannabis works better together. I often say it likes hanging out with friends. It doesn't like to be isolated. In my practice, when patients use at least two or more products, I have a better result, less symptoms at much lower doses, so more cost effective. Could people use one product, one cannabinoid, and get results? Yes, just takes higher dosing. Sometimes that comes with more side effects. So, why? Cannabis likely likes being with its friends for two reasons. It's either something that's happening in the liver when it's metabolized, or something that's happening on this neurocellular level. We see THC completely combine with the receptor when we use THC alone. Um, when we use CBD, it blocks that receptor. THC cannot bind. What happens is we actually get an enhanced therapeutic result. So just know, the more molecules we have swimming around trying to compete for these receptors, lower dosing and symptom control is much better achieved. But it's either the entourage effect or a drug interaction, still under investigation. So how would your clients, how would you use cannabis? How do we use it? So currently, in most states, it is not used in hospitals. However, there are states changing this law. There's something called Ryan's Law in California. Well, now terminal patients can get cannabis inside facilities. And I'll talk about this later, but let's talk about the routes of administration. So inhalation is probably the most known route. So you can smoke it in various different ways or vaporize. Onset is very fast, great for any acute symptoms. It's seconds to 15 minutes. Duration is usually 2 to 3 hours. So it's kind of nice and short. So if you're in pain, you wake up in the middle of the night, you could take a puff of your vape pen and you go back to sleep. But then when you have to wake up for work, you are no longer altered. So that's a benefit. Does sometimes work better for symptom control. It's not as processed in the liver, and then really helps with appetite and nausea. If you're queasy, you don't want to eat anything. So this could be a really great modality. Paste. Paste, RSO oil. These are sublinguals. 15 minutes to an hour goes under your tongue. You can also sometimes put them in drinks depending on how they're made. This usually lasts 6 to 8 hours. A good way to get your cannabis is via oil, paste, what have you. But problems, hard to accurately dose. Sometimes these things come in these syringes, and the problem is there's about most likely 300 milligrams of THC in here. So you have to use only a tiny amount. If the patient has a user error, overuses, you could be really uncomfortable from side effects. But we do have solid clinical research on oils. Edibles are probably the most commonly asked about and most popular. Everybody wants to try gummies, but they can be really strong. So I typically recommend starting with lower dosing of THC, and just, they're harder to find in edibles. So onset is very long. It's actually 1 to 2 hours. So it's good if taken regularly. But if you're using it for like acute onset pain, probably not the best because you have to wait 2 hours. So using constantly is a better modality, or unless you just are comfortable with waiting. So the psychoactive effect of THC is actually longer in this. And the effect of the medicine is longer as well. It typically lasts anywhere from 6 to even 12 hours. It's a little bit stronger than smoking. Why is that? It passes through the liver twice. And that first pass through, it does change the THC compound. It makes it a little stronger. People like it though because it tastes good, it's fun, it's easy to use, but we have to be mindful of how strong it is. Topicals and transdermals are another great modality. Topicals do work, and there is something happening. It's not a placebo effect because we have receptors in our skin. Topical goes here, transdermals do go all the way to the bloodstream. And so transdermals have been really effective for older adults, especially in facilities where, the family can't be there to give cannabis, or the nurses, I've had some facilities have nurses give it, but, nurses and facilities get busy. So transdermal patches are a really effective way to go. Works in about 5 to 20 minutes. Oftentimes works for 8 to 12 hours. If you take the patch off, side effects subside within 20 minutes. Very therapeutic. Downside, patches can get expensive. So that's the only downside really. They're fantastic. So adverse side effects, with THC, that's where you get most of the adverse side effects. But again, this is if you're very irresponsible. Recreational users have this problem more. When you work with a cannabis clinician like us, or another physician or nurse, we avoid this entirely because we know at what point you're going to flip to being uncomfortable. So are there side effects? Yes. Can you die from them? Probably not. Can they get uncomfortable? 100%. So what happens when you use THC? Too much of it. You could pass out, hypertension, hypotension, increased heart rate, decreased heart rate, nausea, vomiting, anxiety, hallucinations. My main worry is drug interactions. While that is mostly being overcautious, just because it's a new science, we're always looking. So far, I was just collaborating with colleagues. We see very little drug interactions. Indeed, if we see drug interactions, they're often positive. It's still something that needs to be worked with on a clinician, because we will oftentimes talk to the patient's doctor and say, hey, your patient's been using cannabis for pain, but also their blood pressure has been lower, they're symptomatic, they're dizzy. What say you about changing an antihypertensive med? It's up to the physician. But oftentimes we do see the synergistic effect where people are coming off various medications because the cannabis is working on many, many things. People also have food cravings, a fast heartbeat, you can feel your body more, but no permanent damage that we see yet with cannabis. And remember, they've invested a lot of money to find that damage. Nothing so far. So now that I've told you side effects, you're probably like, wait, I don't know about this. That discomfort and dizziness doesn't sound the best. Well, and I said I would talk about side effects. Here's a good comparison. NSAIDs are used pretty often in chronic pain. People use it daily. There's a lot of risks that were not talked about: ulcers, GI bleeds. That's why you have to eat a food when you take ibuprofen, but also an increased risk of heart attack, kidney failure, liver failure. So very safe medication are ibuprofen, but cannabis still has a better safety profile. And then if you take away THC, all you have left as a side effect is pretty much dizziness, low blood pressure, sleepiness. So not bad at the end of the day. Why do cannabis clinicians even exist? Well, cannabis is fussy. It's biphasic. It is dose dependent. and it interacts with medications. So we are always looking for getting people here, but that takes time. We do an assessment and a literature review to see what works best for the patient so we can hopefully begin our care here. But typically we have to go up to hit here. I do have some patients that want us to be very aggressive because they have terminal diagnoses of cancer. And so sometimes we'll start over here, but pretty much we help you get right here. So how does one do that? When they work with us, we actually teach them how to self-titrate. We guide them. We give them ranges to titrate. We don't leave you out in the cold. We give you what to titrate. We teach you how to titrate, and we teach you what to look for. So we often tell people to start low, go slow, unless we've seen them tolerate something in the past. But typically you go up by tiny amounts every day to every couple weeks until you have your symptoms reside or until you get side effects. So self-titrating is a really big part of our work and seems to be effective with the nursing process. Just some studies to show how effective cannabis can be, because I am often asked about this. So the studies are growing rapidly. This is an older study that somebody wrote up from Mayo Clinic. When people use cannabis, you see their pharmaceutical pain prescriptions decrease pretty significantly, as well as anxiety and nausea. Everything decreases except for glaucoma, and I know why. CBD increases intraocular pressure, THC decreases it. So if you have glaucoma, CBD is not for you, but everything else at this point is. So that could be why we see the 35 here and not the big leap like we see in everything else. Cannabis hyperemesis syndrome. So I teach about this, not because I think it's going to happen to anybody, but because I don't want your patient misdiagnosed in the ER. And that happens on the floor in the ER. So why does this happen? So, and what is it? So cannabis hyperemesis syndrome is a syndrome where it's typically caused by recreational users burning through receptors or over consuming. And this is after years and years and years and years. There's a hypothesis that this could be related to pesticides or heavy metals in the ground. We don't quite know yet. But the biggest problem that I'm currently seeing on my end is people going to the ER in the hospital and having abdominal symptoms, throwing up, and they're just being, once they admit to cannabis use, this is what a lot of doctors will discharge them with. And in my experience working with patients, I have yet to see anybody with this. It is very real, but it's just very rare. And most of the time, the people in and out of the ER for this have something else that was not caught. So I always tell people to advocate for themselves. If they're diagnosed with this, be sure to say, what else are you looking for? Have you looked for XYZ? Because I have had folks with very real things, appendicitis, gallbladders, get sent home only to come back and it wasn't this. So facility rules, I've talked a little bit about facility, and that's why I wanted to save it. So sometimes the facility doesn't want a resident to have the CBD even or medical cannabis. It is because of Center for Medicare and Medicaid funding. That being said, they're all afraid to get their funding pulled. However, there's no precedent for that, especially because of states having the right to legalize something. The federal government pretty much has stayed out of it, even for facilities that are indeed seeing these patients and allowing gummies in. So just know there's no precedent for that. So if you own a facility, feel free to reach out. We have seen really promising things, but no, there's no case study on losing those funds. It hasn't happened. We've seen a result in decreased polypharmacy when we enter the assisted living facility or facility, rehab facility that a patient's living in, and we see really good results with pain and cognition. How is this done in facilities? Sometimes the patient can self-administer, sometimes the family or caregiver comes to self-administer. And in a couple of cases, how we've gotten people to get cannabis inside these facilities is the doctor will actually, kind of like I'm a wound nurse, the doctor will take my recommendations and write them down, and oftentimes do kind of a verbal order in our MD to RN. So it has happened. We do see a reduction in delirium in these patients, which is really nice because as you all know, as advocates, delirium can be tough on family and staff. So giving them something that really kind of helps make for improved symptoms is really wonderful. So caregiver laws. So what's a caregiver? You could have somebody who can buy medical cannabis with your card and also give you cannabis. In Illinois, you can have up to three, but the caregiver laws vary state by state. So just be sure to check in with your state's public health department or, the Cannabis Commission to see what are the laws. Here, it's up to three caregivers, and I believe it's $50. So what are some other safety considerations? Just some very basic ones. So CBD has been seen to boost liver enzymes. So just be sure to be getting those checked frequently. If you do have a boost in liver enzymes, it is not a big deal. We can decrease your CBD and everything typically goes back to normal. Always check for drug interactions. Your physician may need to adjust dosages depending on how you feel and your side effects. And then surgery and anesthesia, cannabis can alter sedation and sometimes increase doses in the OR are needed. So just hold all products for 48 hours and definitely let your surgeon and anesthesiologist know they use cannabis so they can adjust so they don't have to give you more medicine than you need. How do you find legitimate products? So I find legitimate products. I look for something called a certificate of analysis that tells me everything about the product I'm about to recommend. It tells me how much cannabinoids are actually in there. It tells me, are there heavy metals? Is there arsenic? Is there fungus? Is there pesticide? So I always like seeing a really clean report because we work with a lot of immunocompromised people. So I always just do that as best practice. So always look for third-party testing. And then the Journal of American Medicine, not that long ago in 2017, said 88% of CBD is fake. I would believe that to be true even still. And then within that very slim 12%, you still have a lot of gunk in there, heavy metals, fungus, pesticides. So third-party testing is something we do and easy for us. So we are happy to take that over for you. So first dose at home for 2 hours without driving is always, always, always a recommendation. Overall, do not drive on cannabis. You may be more aware of your body and stay hydrated. The reason why we get dizziness and sleepiness is something called vasodilation. So drink lots of water, it'll mitigate some of that. And that's me. So I'm Rebecca Abraham. I am a registered nurse. I own this wonderful company. And we've seen fantastic results. We run our data pretty frequently. We have about a 90 to 90% success rate in helping people control their symptoms. And what does that success rate mean? We typically have a mild to complete resolution of symptoms using medical cannabis. We do have a couple of case studies, some of which are pending publication and some of which have been published on when we do have these patients who have this complete resolution of symptoms. So thank you, and happy to give this talk. And if your organization would like more of this, I'm happy to do talks, to travel, to do pop-ups, any facility, happy to teach anyone in healthcare from physician, patient advocate to CNA about cannabis and how it can help folks.
Thank you, Rebecca. That was really interesting. I do have a few questions. If an advocate is talking with a physician about possibly bringing in medical cannabis, what would you recommend, that a cannabis nurse also be consulted?
Yeah, the problem is folks at the dispensaries, many of which are very nice people, they know the products, and how they know the products is technically what the company told them. Most companies do not have a physician or nurse consultant. So what the companies say was pretty much made up by the marketing and PR people. So do these formerly called bud tenders, I think they're called like product they have some new neat name. They know the products. They do not know about dosing or drug interactions, and they're not even allowed to talk about it. So yes, I always recommend calling a cannabis nurse or cannabis physician to help with this. And where can you find us? There is more than just me. There aren't a lot of us, so your options are a little limited, but there is still choice. Looking on the Society of Cannabis Clinicians listing, looking through the American Cannabis Nurses Association, the breakdown of how many cannabis nurses there are throughout the country, much less the world, somewhere that are actively practicing independently. 10 to 50, I think, is somewhere of the true number, maybe up to 100. Cannabis physicians are even few and far between, probably somewhere between 10 and 30 cannabis physicians. So those are two places you can look. There's about 1 to 3 of us per state. So you can find us. We do exist technically in all 50 states. But it takes a little bit of searching for us. But I absolutely recommend it because, again, a lot of people think that they could get this information through studies have shown when patients use cannabis, what do? They ask their doctor. If their doctors don't know, I always say, if your doctors haven't come to a talk that we have done or one of my colleagues in these organizations have done, they probably don't know about cannabis. You know, so to always kind of reach out to us, and they always sort of have some stigma too sometimes. So yes, also the dosing is very important. So a lot of times the folks at dispensaries will say that they know, but they're using sometimes pseudoscience or bad information. And then of course Google is no better. A lot of the websites that exist to guide people are kind of marketing vehicles, and not scientific in nature. So
Good. And if someone wants to get more education on medical cannabis and maybe even become certified um, themselves, because this is a growing area, I believe. So where would you recommend people go to get education?
yeah, I would recommend for nurses, the American Cannabis Nurses Association has a couple of programs that you can do. I kind of did this very early than most cannabis nurses, although cannabis nursing has existed since 2010.
Mhm.
I started doing this in 2018, 2017. I started really getting into the literature and the reading. But now there's an entire course at the Pacific College of Oriental Medicine, has like a 6 months to a year course on this, but there are other courses. Really depends on where you are in your reading and what kind of nurse you were. So critical care nurses, this is actually a really great fit for us because you're already used to titrating medications. So you're just titrating supplements. So it's very similar. Wound care nurses, great fit there too. So those are the two places. The Society of Cannabis Clinicians has classes too. That's what our physicians use. Really great. There's a lot of really great books, especially if you're very new to this. So Dr. Kogan, he has a great book on medical cannabis. There is Bonnie Goldstein has a great book on medical cannabis. Hopefully me and some of my collaborators, we're hoping to at least write like a basic guide soon. I keep promising it's coming one day. So those are some authors that are great. If you're a nurse, Dr. Carrie Clark actually has I'm looking at it now in my bookshelf, Cannabis, a handbook for nurses, really great for nurse practitioners and nurses too.
Great. And we'll look for your paper. I'm
Yeah.
sure you're going to be publishing more. We would love to have that.
Yeah, and we are always trying to do case studies as much as we can in research because the biggest argument against medical cannabis is there's not enough research. And what we are seeing is these really positive results. So when we see something, we try to write it up as fast as we can and get it out there because these things build on each other. So if
Mhm.
you've had a patient that uses medical cannabis, if you've seen a result, even with CBD, please reach out to us and we would love to kind of put that on paper and submit it. The societies and these peer-reviewed journals and these associations oftentimes are very difficult to get published with cannabis. But as we submit more, it comes to light more, and then the physicians learn and the nurses learn. And so we're kind of slowly making some headway.
Great. I know on one of the slides you talked about like the cost of medication and the cost of care for people that are chronic patients. And you said medical cannabis is an alternative. So what is the cost of just a roundabout? I know it probably differs around the country, but what
Yeah.
would you say the cost is?
So cost is a little bit of an issue actually, because remember our services and the cannabis medicine or supplement, it's not covered by insurance either.
Mhm.
HSA and FSA payments are taken both for medical cannabis as well as our services and other physicians and nurses like us. So that's good news.
So what
Um,
were those initials? HSA health
yeah,
savings accounts?
healthcare spending accounts and flex spending accounts.
Okay.
That's currently kind of all we have, but cost. So it's all self-pay, unfortunately, and the products are all self-pay. But I will say this, when you're hiring a cannabis clinician, will it cost a couple of $100s, per appointment? Prices to see someone like us nationwide vary from about $50 an appointment all the way up to $300 an appointment. I could speak to our program. We actually do ours in packages. Why? Having a one-off appointment with folks doesn't work because it's a titratable and very kind of fussy substance. We see results 3 to 8 appointments. So we bucket it in packages. So when you break our package down, we cost about $50 to $75 an hour. So and that's very intentional. So everyone can access this. As far as what the cost is to purchase cannabis, Illinois is one of the more expensive states, DC as well. Boston is expensive, but some states are very economical. New Mexico, California, Michigan are states with some very low prices. I know patients in Illinois oftentimes ditch the medical card and just go to Michigan because the recreational side is cheaper. Products, flower is the cheapest, but not everybody wants to use that. That's the might have some here. Nope, I don't. That's, what you would put into a joint. Usually that cost about $30 for a jar that's this big. These oils can go from $25 all the way up to $70. Is it worth it once you find the right dose? And that's the other reason to kind of recruit a cannabis clinician in any of us, honestly. Is because we make that process a lot faster. Otherwise, people experiment in progress and in products, they waste a lot of money. So we hone in, we figure it out pretty fast. And then, does cannabis cost money? Yes, but we do see a decline in use of pharmaceuticals, increased quality of life, improvement in symptoms. And so is the cash buy-in worth it? Yeah, especially when I've seen
It
folks.
sounds pretty affordable. It doesn't sound, I always thought you were going to say like $5,000.
No, remember people have to kind of re-up monthly, bi-monthly. So it is not after our services, another cannabis clinician services, that's probably somewhere $100 to $400. But after that, your cost is typically about $100 to $200 a month. So for some folks, I know that's not easy, but it does get the job done for a lot of people. So it all kind of depends on where you're at. There are folks I'm working with a lot of cannabis clinicians in the Midwest and even nationwide to find a program where we can have provide our services and do public-private partnerships.
Maybe even some of the cannabis provider growers would support it for when there's a financial need.
Absolutely. And so we're trying to get a bank account to some sort of funding where people can buy this because there are populations, in my graduate work, I look at chronic pain a lot, particularly for at-risk populations, folks like the sickle cell population, right? A community that's been really harmed by the stigma of cannabis and the war on drugs did a ton of damage to the Black and African American community. So people in the sickle cell population are oftentimes very frightened to use cannabis in the first place. And then it can get expensive. So that's a population that I think with a public-private partnership could be really benefited with this decreased length of stay, hospitalizations. In the end, the healthcare companies could win too, because what do they look at? Readmissions and length of stays.
Right.
And then the cost of a card varies by state. I could speak to Michigan, Illinois, typically about $100 to the state, somewhere between 50 and 100. Most of the times there's deals for veterans and older adults over the age of 65, or if you're on Social Security. And then a caregiver is somebody who can get the cannabis for you. Usually to add one person on, it's about $50 a person. I recommend a cannabis clinician that can certify you in whatever state you're in. Why? There's a lot of pop-up card shops. You see them everywhere, right? When you look up cannabis, where can I get my cannabis card? You see a doctor for $300, get a card. They're just giving you the card, no information. And then they never click lifetime condition. In a couple of states, there's an option for the physician or nurse practitioner or PA to click lifetime condition. So you never have to pay another physician again to do this. A lot of people don't click it because they want the renewal. So know that, on the more medicine-y side of this, we have no interest in making people come to us every 3 years. We would just rather give folks what they need, because we know your rheumatoid arthritis is unfortunately probably going to be there for a while. So
Yeah, right. Now, are there any conditions? I know you talked about a lot of the conditions that it could help. Any conditions that it would be contraindicated in, like mental health or,
That's a fantastic question. So a lot of things that we thought cannabis was contraindicated in turns out to be false. There was just a study released, and I had been thinking this for a while. There was oftentimes a concern for mental health and triggered by THC in cannabis. It turns out that that's probably not true. There was a really large study done on schizophrenia. I think the study population was over 10,000, but there was really no causation. Why was there a correlation? If we think about who is overusing cannabis, right? It's mostly adolescents and teens who are mostly using it recreationally. I don't know if I like using this as an example. I like using this. So how cannabis works kind of will show us when things go wrong, why things go wrong. So remember how I said that we make our own cannabis. So this is a normal receptor, it filled up with that abnormal. As we age, we lose receptors, we get sick, we have viruses, we have trauma, we start not making enough. When we fill it up with plant-based cannabis, it happens slowly over time, and everybody's different for how long it takes to refill the receptor. We feel better. When you overuse, this is a hypothesis, but it seems like it could happen. When you overuse cannabis as somebody with a very normally functioning system, so and you're using high THC products, you're using it every day because you're young, you're having fun, you're looking for the euphoria. There's a theory that it can burn out those receptors, and that's where you see side effects. The age of people that do that is typically 16 to 25. The most common age of diagnosis of schizophrenia is 16 to 30. So I feel like correlation less than causation. I looped around. So what should cannabis not be used with? Cardiac health immediately after an injury, I would say, is the most important time to stay away from cannabis, and not forever, but at least the first 6 months to a year. Why? There are two reasons. Mostly what I know for sure is a medication interaction. When you have an intervention, so you go to cath lab, you go to PCI, or you have a cabbage, right? Or even this could even happen with aneurysms. You get a coil, you need that to stay open, stents, any stenting, right? Where you're on Plavix in particular. I do not recommend cannabis for 6 months to a year. There is a noted drug interaction. We don't know how potent this is, but it could decrease the circulating amount of Plavix, which could make you reclot. So we absolutely want your stents to stay open. There was a conference talk that talked about repeated need for cath lab and PCI in patients using cannabis. It was smoked cannabis. The variables weren't all cut out, but I believe what that doctor saw happened. And I wonder if it's because of this interaction with Plavix. So just to be on the safe side, I always say 6 months to a year. No, thank you. We'll talk to, the patient after a year, and we'll talk to your cardiologist as well. There's also a little bit of concern. Some of the endocannabinoid receptors are in our cardiac muscle. And there is a thought where if you are somebody at risk for an arrhythmia, or if you overconsume THC, like that population of adolescents that are really overdoing it, could you trip yourself into an arrhythmia? We don't know that yet. That's one possibility, but I don't remember if I said in this talk or the talk I just did, but there's been about $1 billion tossed at cannabis to research it. But what has a majority of that $1 billion went towards? Looking for the negative side effects and harms of cannabis. Only about 1 to 5% went for looking for therapeutic benefit. So are there probably downsides? Of course, there's no free lunch in anything in healthcare, but it seems like those downsides are going to be very few and far between because we've spent so much money trying to find them and can't. And think about all the drugs where we found the positive and we spend no time looking for the negatives, you know. And I will say that if you've had an intervention and you are on Berlenta, is not a completely closed door to using cannabis. It's just something that we would prefer to talk to your cardiologist about. So cardiac intervention, cath lab plus Plavix is a no. After 6 months of a non-emergent stent, we could talk to your cardiologist if you're on Berlenta.
Okay. I think that's great. And, you know, again, thank you for your time. Thank you for educating us. This is an emerging topic and something we're going to see more and more of. So it's great to get a baseline and then to move forward from there. So thank you for your time. We look forward to continued success.
Yes. Yeah.
As you get your doctorate, but thank you. And we'll look forward to keeping in touch with you.
Yeah, absolutely. Thank you again.
Okay.